Good morning and welcome to the fifth meeting of the Health and Sport Committee in 2020. We have received apologies this morning from David Stewart, MSP. Can I ask everyone in the room please to ensure that mobiles are off or on silent and please not to use mobile devices for photography or recording proceedings. The first item on our agenda is an evidence session on the budget for 2020-2021. Our approach to scrutiny of the budget has reflected the approach recommended by the Budget Process Review Group, which involves addressing budget implications throughout the year and bringing this information together to inform a pre-budget report for consideration by the Government. Our pre-budget report was issued on the 3rd of October, setting out some recurring themes and issues identified in relation to Scottish Government plans. Obviously, the timing was different this year from usual for the usual reasons, but we received a response from the Cabinet Secretary to that in some detail on the 6th of February. So I'm delighted to welcome to the committee this morning the Cabinet Secretary for Health and Sport, Jean Freeman, who is accompanied today by Richard McCallum, Interim Director of Health, Finance and Governance at the Scottish Government. Welcome, Cabinet Secretary, and I believe you want to make some initial remarks.
Thank you very much, Convener, and good morning to you and to colleagues. As always, I welcome the opportunity to give evidence this morning on our budget proposals for health and care services. The 2021 budget puts in place the funding that we need for continued improvements across the whole system, improvements to patient care, and to deliver better health and better value for the people of Scotland. To deliver this, the draft budget spending on health and care services will exceed £15 billion for the first time. The funding settlement sees every penny of additional health resource and capital consequentials passed on in full, and in addition the Scottish Government has allocated more than £100 million over and above consequentials, specifically to support the NHS in Scotland and to mitigate the impact of funding shortfalls from Westminster. Through this budget, we will continue to build on our record level of frontline health spending in Scotland, which is currently £136 per person. That is 6.3% higher than in England. To support the measures set out in Health and Social Care Medium-Term Financial Framework, funding for frontline NHS boards will increase by £454 million, that's 4.2%. This underlines our commitment to frontline services and delivers funding greater than the requirement recognised in the financial framework. We've also ensured that all NHS boards are within 0.8% of their target funding shares, the closest that all boards have been to parity since the formula was established. To support the measures in our financial framework, the Scottish Government will further increase its package of investment in social care and integration. This investment will increase by a further £100 million, taking the total package of investment to £811 million from health portfolio, underlining our commitment to support older people and those with long-term conditions and recognising the vital role undertaken by unpaid carers. Through these measures, we have ensured that we remain on track to deliver more than half of frontline spending in community health services by the end of this Parliament. We have key investment areas in terms of innovation, in hospital at home, in attend anywhere, in digital and in thrombectomy. Our budget will deliver increased investment in waiting times of £30 million, building on an additional investment of 146 over the previous 2 financial years, continuing our efforts to improve access to hospital-based services through our waiting times improvement plan. We will make an additional £12.7 million available to tackle the harm associated with the use of illicit drugs and alcohol, a 59% increase in direct funding from the Scottish Government, and comes on top of spending baseline to NHS boards to address these issues. We are clear, however, that we need to do more to support reform and ensure the continued delivery of sustainable person-centred services. Our investment of over £9.4 billion in health and social care partnerships is key to achieving this reform, as well as our direct investment to improve primary care and mental health. The investment in primary care supports the implementation of the new GB contract, making sure that general practice continues to be an attractive career and safeguarding service provision now and for the future. We will also take forward our work to build multidisciplinary teams within primary care, making sure that patients can see the right person at the right time, improving access and outcomes. The budget will also deliver additional funding for mental health services, underlining our PFG commitments to support positive mental health and to respond effectively where mental ill health is experienced. Our 2020-21 funding will widen approach and access to children and young people's mental health services, as well as progressing our commitment to provide 800 additional mental health professionals by 21-22. We will also implement new measures to improve in our approach to mental health, such as the Adult Mental Health Improvement Collaborative and the Distress Brief Intervention Programme. The draft budget also includes funding support to increase bursary provision for student nurses and midwives, and to continue our increase in training places for the medical, nursing and other areas of the workforce. We know that being active is one of the best things that we can do for our physical and mental health. The 2021 budget will continue to support people in Scotland in this area by investing in places and spaces to provide opportunities for all to participate in sport and physical activity. We will continue to work with Sport Scotland to protect sport investment, and will continue to underwrite potential shortfalls in lottery funding as we have done in previous years. In terms of capital investment in 2021, this will increase by over £90 million to £428 million. Investment in our infrastructure will be used to support delivery of the Baird Family Hospital and the Anchor Centre in Aberdeen, as well as to increase elective capacity across the country through our elective centres. Excuse me, we'll also provide additional resource funding to continue implementation of the Scottish Trauma Network, supporting the development of 2 centres in Edinburgh and Glasgow to add to those already open in Dundee and Aberdeen. And finally, in conclusion, Convener, the Scottish Budget for 2021 does take investment in health and care services to over £15 million for the first time. We will protect frontline services and continue to shift the balance of care towards community health services. We will continue our twin approach of investment and reform of primary and social care, mental health and waiting times, and will ensure we maintain a strong focus on our NHS values, delivering care which is safe, effective, person-centred and timely. And I commend the budget to the committee.
Thank you very much, Cabinet Secretary. And if I may, I would like to start with the point you mentioned at the very end there about shifting the balance of care to community health services. This is a matter in which the committee has supported your direction of travel, but asked you previously, and I'll ask you again this morning. I think the last numbers we had for end-of-year operational outcome was 49.7%, where the target is over half. Is it your expectation that you will pass that mark in this year's coming budget? And if it is, do you still hold that that's a sufficiently ambitious target, or do you believe that you can go beyond 50%?
So our target is 50% in the lifetime of this Parliament. I think from memory, the current draft budget is 49.7.
So 49%.
That 0.1% though represents an additional £200 million. So my expectation is that by the time we get to the next budget, we will have reached the 50%. I think, Convener, whilst the 50% figure is important, what is equally important is how the money is spent, and whether or not we can ensure that we have the right levers to ensure that that additional resource, which is significant, does secure a shift in the balance of care. And that particular aspect of how the money is spent and how you can be sure that it achieves the outcomes that you seek, we've discussed before in this committee, and has been the subject of continuous discussion between myself and our COSLA colleagues, in particular my counterpart, Councillor Curry. And so we are moving now to an approach which is around shared accountability, because of course shifting the balance of care is one which requires an effective partnership with our local authorities in terms of the investment that is made jointly in these areas. And I'm hoping that the discussions that are continuing still will produce some additional positive steps whereby that commitment to shared accountability for shifting the balance of care can be more effectively realised and more clearly reported to you and colleagues, but more importantly to the wider Scottish public.
Thank you very much. Clearly an important part of that 50% target or commitment is to reach 11% in primary care, again by the end of the current Parliament. I wonder if you would could comment on progress on that in this year's budget.
So in this year's budget, that remains on track. We are at 10% is what is planned with the proposals that are in this year's budget for the additional spend in primary care will take it to 10% of the overall spend.
So I guess looking at both of these commitments, what would be interesting, you said in your previous answer you would look to be more effectively presenting or reporting on progress in these. What is your anticipation in relation to primary care? Clearly that's quite a substantial jump. If you've made the point, I think 0.3% on community health is quite large. 1% on primary care, by definition, is even greater. What's your plans for delivering that and for indicating progress towards that?
So primary care is part of the whole integration agenda, and it is a significant driver to shifting the balance of care. Part of the work that is undertaken in primary care centres around the new GP contract, but centres around that GP contract in terms of producing the multidisciplinary teams. So the additional pharmacotherapy services, physiotherapists, occupational therapists, depending on what individual GP clusters want, mental health officers, which I've already touched on, and so on. There has been significant progress made in the delivery of that GP contract. From memory, over 80% of GP practices now have access to pharmacotherapy services. That makes a significant difference to patients, but also to the GP's workload, allowing the GP to be to have the time to be that local clinical leader that the contract asks them to be, and hopes to elevate their status. In addition, an increasing number of GP practices are becoming teaching practices, which we need because we've increased the numbers of both undergraduate and foundation year and specialist training places in GPs training, so that we increase the number of GPs. So primary care is, from the health perspective, a key driver of integration. But primary care not only is about what goes on in the GP practice, it's also around how we engage with mental health services. I mentioned mental health officers, but also with our ambulance service, in particular with the growth in paramedics and prescribing paramedics, and the link we've begun the rollout of, for example, hospital at home, and the move of a number of outpatient services from a hospital setting into the community setting. So that work is underway. We will continue to report on our progress against the GP contract, phase 1 of the contract, and our discussions with the BMA, I met them last week, around the completion of phase 1 and phase 2 and the timeframes for all of that, as well as reporting on how we are progressing on the 800 mental health officers, the community link workers, and all of those. What I'm keen, which is why I mentioned it at the very outset, is that we understand all of these elements as part of that whole system approach. So mental health officers, community link workers, the GP contract, multidisciplinary teams, all of those are central to shifting the balance of care.
Thank you very much. I know committee colleagues will have questions on all of those in the course of this morning. Brian Whittle.
Thank you, Convener. Good morning. Cabinet Secretary Gordon Mr McCallum. Can I ask questions around the medium-term health and social care financial framework? I think the framework identified the need for savings of about 1.7 billion over the period 2016-17 to 23-24. So can I ask, in the first instance, what levels of savings will be expected of health boards and integration authorities in 2021?
So the first thing I want to say about the framework is, of course, as I said in my opening statement, and I know you will recognise that the increase that the draft budget proposes for boards is greater than the financial framework says is required, and that is a significant increase to those boards that helps work towards the overall funding gap that the framework identified. In terms of the specifics of your question, I'm going to ask Mr McCallum to deal with those.
Yeah, so in terms of the savings that boards are required to make in 2020-21, we're still working through their financial plans at the moment. The timing of the budget's just meant that the agreement of boards' annual operational plans is slightly later than in previous years. But what we've had back initially from health boards is that they're looking to make savings of around about 3.9% in 2020-21. And I guess to give some kind of idea of how that compares for the committee, that's broadly equivalent to what boards had to make in 2019-20, and actually a bit less than what it was in 2017-18 and 18-19 when it was closer to 5%. So we track that savings target very closely, and that's a key part of delivering the medium-term financial framework, as you say. So part of that is about additional investment that goes into the system, as the Cabinet Secretary says, and part of it is about that ongoing delivery of recurring savings that boards and IJBs need to make.
You mentioned there, Cabinet Secretary, that there's an additional funding gap of £159 million was identified in the initial financial framework. And you've, in your answer there, you suggested that you've gone the current financial settlement has gone some way to closing that gap. Can I ask then, have we got have you identified the means to close the whole gap there, or have we still got some work to do in that?
So, I'll let you.
So the framework runs through to 23-24. So that 159 million, which I think was the level of the gap that we said at the end of that period, that will be built. You know, that will be a position that we work towards up to 23-24. So the steps that were taken in 2020-21 is a key part of us going towards that position at the end of 23-24.
So if the initial figure that was come out was 159 million, where so an indication of where we are now, given the new financial framework? Well, in your answer, you suggested that the settlement, the financial settlement for the board had gone some way to rectifying that 159 million, or at least finding that extra 159 million. So I'm just interested to know where we think, where you think we're sitting just now.
So the board allocation that is over and above what is recommended in the medium-term financial framework will be a contributor towards meeting that overall funding gap. But as Mr McCallum said, it needs to be made up of a number of different elements. And as we work through the board's annual operating plans, which include their financial plans, that will help us to understand how much closer we are towards reducing that 159. And then we will continue to work through that this year and in the next budget for the following year as well. So again, as we see the board's monthly reporting in terms of their financial position, then we and you will be able to see how we are making progress towards that 159.
Thank you. I think also there's in your answers to the convener there, we talked about the measures that shifting the balance of care from hospitals, looking at obviously better regional working and other public health measures. And I wondered what savings you anticipate from that kind of shift and from those kind of measures.
So shifting the balance of care is, if you recall, I think I've said this before, I'm sure you might recall, that when the health service as a whole moved from institutionalised care for people with learning disabilities and others into care in the community, the health service at that point was in a fortunate position that it could fund, in effect, a degree of double running, where you continued to keep the institutions open while you built up the community provision. That has not been an option for us in terms of shifting the balance of care. So we need to do the shift and invest in primary care and integration, and then see what that means in terms of the demand on acute services. We can anticipate what we think that means in terms of the number of conditions that can be treated in the community as opposed to requiring acute hospitalised care, or how the hospital stays can be shortened. But there are other factors that come into play in that. So, for example, in orthopaedics, in Fife, they are now doing day hip replacement surgery. That is a significant shift in hospital, in stays in hospital, which has to play into then what number of beds do we need, how do we maintain the right level of beds in order to cope with peaks and demands over, for example, winter periods. So there's a significant piece of work that needs to go on before we can fully say that by shifting the balance of care, we have released a certain amount of money from acute care. And I don't believe we're exactly at that point yet where we can say that we can give you a number with complete confidence, because innovation in medical procedures also contributes to a reduction in what you need in the acute setting.
Okay. And finally, just to ask if you intend to publish any update as we're going on in the medium-term health and social care financial framework, that this committee can have a look at.
What we can produce, we have no plans to produce a new medium-term financial framework, but what we can do is, if there are particular areas in the medium-term financial framework that the committee would want an update on, then if you let us have those, then we will respond quickly, as we always do, either with the update or when we believe we can provide the update.
Thank you very much. Emma Harper.
Thank you, Convener. Good morning, Cabinet Secretary, and good morning, Mr McCallum. I'm interested in just a wee suck to Brown Whittle. Attend Anywhere as part of shifting the balance so that people don't make hospital appointments or have to travel distances. So, and you've heard me going on about it for the 150-mile round trip from Stranraer to Dumfries, for instance. So that's part of shifting the balance of care, engaging in digital technology such as Attend Anywhere and other stuff. We will be able to measure that and see how we can show savings from implementing that kind of technology. Is that correct?
Yes, we will be over time as more and more patients use it. Attend Anywhere, or Near Me, it is sometimes called in other parts of the country, is growing in pace in its rollout. Similarly, Hospital at Home, which I know you'll be familiar with in terms specifically of Lanarkshire. It comes a bit under other names elsewhere. We've now begun the active rollout of Hospital at Home, which does two things. It helps to promote early discharge for individuals, but it also prevents hospital admissions, where people need maybe have longer term conditions or frailty and need a level of acute care that does not require to be delivered in an acute setting, but with with the right clinicians doing that. So Hospital at Home is also now being rolled out, and over time, as we understand the numbers using those, then we will be able to evidence what we believe is a saving overall in terms of cost, but particularly a saving in terms of patients' time.
Okay, thanks.
One other simple question on financial planning and strategy, the Scottish Government's overall medium-term financial strategy. The first one in 2018 included portfolio plans, including for health. The second one did not. Do you know what the plans are, or have you come to a view as to whether portfolio-specific plans will be included in the medium-term financial strategy when it's published in May this year?
So that is largely a question for Ms Forbes as our new Finance Secretary, and I'm sure I'll have discussions with her. I am comfortable whichever way she wants to proceed.
Okay, thank you very much. Alec Hamilton.
Thank you very much, Convener. Good morning to the Cabinet Secretary and good morning, Richard. I'd like to start by asking about brokerage. Obviously, we're changing the system now where we have forgiven the debt, the considerable debt that some health boards had accrued through brokerage. And now the in-year funding, additional in-year funding, will be expected to pay back. Given that health boards were arguably sent a message when we wrote off that debt that the government will not allow those health boards to fail, what confidence do you have that any in-year funding given to health boards will be paid back in the future?
So part of what we did too, remember, was also give health boards the flexibility of 3-year financial planning with the discretion to, in each year, to be plus or minus 1% with the commitment that at the end of year 3 they had to break even. So that allows much more normalised, I think is probably the right word, financial planning for health boards. In terms of how brokerage is handled, I'm going to let Mr McCallum deal with the detail of that.
Yeah. I mean, I think your question, Mr Cole-Hamilton, you asked about confidence, and I think one of the key things for us is that the 4 boards who had their brokerage written off at the end of 2018-19, they had to agree a plan over 3 years that they would return to financial balance. And one of the key things in terms of our confidence is that those boards are in line with the trajectories they set out when they agreed that 3-year plan. So if I take those 4 boards, 2019-20 obviously represents the first year of this 3-year return to break even. And in all instances, the boards are either on track or actually slightly ahead of planned position at this stage of the year. So the key thing for us is to see those boards back in financial balance as soon as possible, and in that 3-year period. Once we've reached that position of those boards being back in sustainable financial balance, then we'll work with them to consider how that brokerage, which they've received subsequent to 2018-19, is repaid.
Okay. Further to that, there are lots of boards who didn't receive brokerage in the last few years, but may well need it in the future. We can't predict what sort of financial impacts things will happen in boards or increase in demand, unforeseen circumstances. Would they not point to the brokerage that was extended to those 4 boards that had their debts written off and ask for similar treatment in the future? What is to stop them? I mean, it doesn't seem particularly fair that this was one rule that 4 boards benefited from that can never be extended to other health boards.
So that was a discussion, if you like, that was had with all boards at the point when we introduced the situation that you've described. And it is undoubtedly the case, and boards have made this point, and I completely accept it, that looked at from one perspective, it was unfair on those boards that had managed their finances and broke even and taken some difficult decisions. But what they all understood was that it was a necessary step in order to provide a degree of stability and forward sustainability to the health service as a whole. And therefore, they all accepted that all of them have to, over a 3-year period in a rolling cycle, break even. And so all are working on that basis. I think that the other part of that, so in addition to, as Mr McCallum said, with the 4 boards concerned, being confident about how they are making progress against the agreed trajectory, and that they are either on track or ahead, in terms of all the other boards, there is that degree of consistent reporting and monitoring so that we can anticipate with board chief executives and finance directors where there may be difficulties emerging and work with them at that early stage about what needs to be done in order to manage their way through anything that is unusual in their particular circumstances.
Okay, I'm grateful for that response. If I have one final question on brokerage, just for the record then, Cabinet Secretary, you're saying that this government will not forgive any further brokerage debt accrued by any NHS health board in Scotland?
No, our clear position, and with all the boards, is that we expect boards over a 3-year period to manage their budgets so that they end each rolling 3-year period in a break-even position. And we do and are prepared to put substantial resource through the form of expertise and support to help boards do that.
Given a 3-year framework, as you've described, will boards be provided with 3-year financial indicative allocations?
Well, that's quite hard to do because our Scottish Government budget is not a 3-year budget for all the reasons that convener and colleagues know. What boards can operate on is that the budget for year 2 is not going to be less than the budget for year 1. And so they can work forward on that basis, knowing that it is a reasonable presumption on their part that there will be an increase year on year. What they cannot know, and I cannot tell them, is what that level of increase will be.
Understood. Thank you very much. Brian Whittle again.
Thank you. Just briefly on that one, I meeting with Ayrshire and Arran about 10 days ago, and I know they had significant brokerage, and they're making good progress against some of the targets. But the indication was at that time that they can't quite see where they're going to get to break even by year 3. I just wondered, from your position, Cabinet Secretary, what would happen to them at that point if they haven't broken even? Where do they go from there?
Well, they're in year 1 at the minute, right? So year 3 is 2 years away. And the job of Mr McCallum and his colleagues is to be working with Ayrshire and Arran now, looking ahead at what is it that is providing that concern to them, and what might we with them do in order to help them get to that break-even position. So it is in one sense positive that in year 1 they are worrying about year 3. That's a good thing, as opposed to waiting until year 3 hits you. The other side of that is that allows us at this stage to be working closely with them to identify what are the concerns that are giving them that worry about year 3, and what can be done that may assist them to get over those. I don't know if Mr McCallum wants to say anything more about exactly how we work with boards, but it is a very, depending on their need, intensive level of engagement and support.
Yes, I suppose as you would expect me to say, we do work very closely with the boards, particularly those in financial deficit, and have worked and have agreed kind of tailored packages of support for those boards. So if we take the example of Ayrshire and Arran, there has been people both from within the finance team in Scottish Government and in other directorates who have specifically gone and helped support the Chief Executive and his senior team with the financial planning work. I think what I would say is, as the Cabinet Secretary has mentioned, we are working through these 3-year financial plans at the moment, and there is more work to be done, and there's more work to go on at this. And I think we will continue that close engagement with Ayrshire and Arran, as with every other health board, to make sure we are clear on the position and we're doing all we can to help and support them as they develop those plans.
Yeah, thank you.
Brief supplementary, Sandra.
Thank you very much. Just a supplementary on this particular issue about the financial planning and obviously write-off of any debts or monies which was owed. I'm glad that Greater Glasgow Health Board weren't one of the boards, which is very, very good. But picking up on the points, yes, debt was written off. I'm assuming then, for clarification for not just me but the committee as well, that there's ongoing talks, and also has there been identification of why these particular boards did not meet the criteria, because, you know, obviously, as been raised by Mr Whittle, Ayrshire and Arran, who were one of the previous boards, appear to be in bother again. And I just wonder if, you know, there's ongoing talks in regards to why these particular boards were, you know, money-wise compared to other particular boards as well, and the identification of where the money has been overspent, just for clarification for the committee.
So, so a couple of things. I think, to be fair, Ayrshire and Arran it wouldn't be fair to say they're in bother again. They are on trajectory, but they are worrying about whether or not they can get to a break-even position by the end of year 3. I think that is, as Mr Whittle described it, and we've described what we now do with that board and any others in that position. I think the other thing that it's fair to say is that, notwithstanding the additional investment that we are making in health through boards, excuse me, it is for all of them a financially challenging position. And so it's not particularly the case that some boards were particularly deficient in their work compared to others. It is challenging for them all. Some boards made particular decisions about how they would deliver services that created debt. Others made different decisions that arguably may have damaged the delivery of services in some respect, but financially broke even. What we have to do is work with them so that they can manage the decision making in a way that does not negatively impact on patient care and access to service, whilst managing through the financial challenges. A lot of that is around reform of how you deliver your services, and some of it relates right back to where we started, which is shifting the balance of care. Yeah. So, for example, it's not only beneficial to patients if outpatient services can be delivered more locally than in the acute setting. It is also, over time, a more efficient use of resources. There are a number of factors that you need to bring into play to make that happen. There is the workforce planning, the planning of consultant and other staff rotas, ensuring that you've got sufficient premises for that to happen, and planning the timing of appointments and so on. So all of those factors have to come into play. All our boards, a bit like our integration authorities, they all do some things very well indeed, and others where there needs to be improvement. And it's not the same across the country. So part of our role is to help boards link with each other where improvements have been made in service delivery, which have also proven to be a better value for money, as well as the additional financial expertise and support that Mr McCallum and his colleagues can provide. I don't know if you want to add to that.
Yeah, so you're absolutely right. I mean, the key first step is actually understanding what's the driver in terms of why the board has required brokerage. And while there might be general factors, sometimes there are specific factors as well. So if we take the case of NHS Tayside, which this committee will be familiar with, as well as the Public Audit Committee, Tayside was running a particularly expensive operating model, and for things like prescribing, they were a significant outlier with the rest of Scotland. So whilst there can be general factors, there can also be specific things. And so we did a lot of work with Tayside over the last 2 or 3 years to look at their prescribing practices and work with them to have a more efficient approach. So I think there's and there'll be other things as well. There'll be things around financial planning, leadership capacity, and we work with the health boards to understand what that is and provide that tailored support that's needed to get them back into the financial position that we need and expect them to be in.
If I can just add, Convener, as well, it's just a point worth making. This is where, for example, another area where the Chief Medical Officer's work on the Atlas of Variation can be of real value overall in terms of the model of service delivery and the related financial cost of service delivery. Now, the ideas, the origin, if you like, of some of the Atlas of Variation work sits in orthopaedic surgery. where across the country variations are identified in length of hospital stay. When clinicians look more deeply at why are those variations, the variations often are not clinically driven, so there's no clinical need for someone to be in hospital for twice the length of time than someone else for the same procedure, given the particular patient is comparable. And so you begin to look at what is driving that additional length of stay that is not clinically needed. You can begin then to take the steps to reduce that, and that produces a level of financial gain that you can invest in other areas of your work.
Very comprehensive. Thank you.
Thank you very much.
Thank you.
In addition to the question of brokerage, the other question, I guess, the other measure of challenge for boards is the escalation framework. And I was pleased that after we'd requested that you now publish that regularly. Clearly, current position would appear to be a very challenging one. I'd be interested in your views. We have Greater Glasgow and Clyde and Tayside and Highland and Borders and Lothian in respect of the New Children's Hospital, all at stage 4 of escalation, and Lothian in other respects, and Ayrshire and Arran at stage 3. That's quite a substantial part of the health service in Scotland in relation to territorial boards. What is your general view about how that position has arisen, and what is your expectation, or what are you demanding of boards in terms of returning to stage 1 or stage 2 of that framework?
So there are different reasons why boards are at level 4 or level 3, and generally speaking, that is a mix of either financial performance or performance in the delivery of quality of care to patients. And so the approach we take differs depending on which of those reasons, or where there is a mix of reasons, that a board is at a particular escalation level. What I think, and I do genuinely believe this, is that what it is an indicator of is it's an indicator of active NHS national engagement in improving performance, both financial and service performance, and that should be welcomed. All of the boards, particularly where they are at level 4, will have what's called an oversight board, chaired by a senior person in the Health Directorate, so either the Chief Nursing Officer or the Chief Operating Officer, with others there to help the board both to monitor and manage the improvement programmes that are in place, but also to help individual boards make improvements that are sustainable. So in the case, for example, of NHS Lothian, they're at level 4 on the basis of the fact that we couldn't open the sick kids. As that, they have a programme manager who is directly accountable to me as a Cabinet Secretary for the work that she's undertaking. She's working with the board. The Oversight Board is overseeing that. As that work progresses, and provided it meets the timeline that I've set out and can open safely, both DCN first and then the whole hospital, then I would expect NHS Lothian to be de-escalated from level 4 because that piece of work has been undertaken. We'd want to be assured that lessons have been learned and so on. As boards move in terms of financial performance along the trajectory of the plan that Mr McCallum set out, as they continue a consistent, steady movement, then an assessment will be made as to their capability to continue without being at level 4 in order to secure that. So it's not something you can say a board is at level 4 for X amount of time. It's at whatever level it is at until we are confident that the improvements that are required are both being made and are sustainable.
But I take it from what you've said that in each board you have set out to them a timeline for when you expect them to reach that sustainability and return to a lower level in the escalation framework.
Yes, so they all have recovery plans.
Yep.
And those have timelines attached to them. In terms of financial performance, as Mr McCallum has said, in Lothian's case, just on the level 4 in terms of the new sick kids, there's a clear timeline for that. And as they make progress, then we actively look at whether or not a board can be de-escalated. I am conscious of the value to a board of its progress being recognised by de-escalation, and to the service as a whole, that boards understand that, you know, not only can you be escalated, you can be de-escalated, but there are improvements that are required. Otherwise, the escalation process is pointless. And the escalation process is about bringing in additional support, but depending on the level, additional direction in order to secure the kind of improvements that we need.
Given the concerns that clearly will exist in each of these areas for different reasons, do you intend to make these timelines public for these particular boards?
Well, the financial projections, the boards that are at a particular level, given their financial position, those trajectories are there, sure. And I imagine are reported in terms of the board's reporting. Lothian Sick Kids, people know the timeline I've set out there. Greater Glasgow and Clyde is of a slightly different order because there are two areas. It was initially escalated in terms of infection prevention and control and engagement with patients and families, information sharing and engagement with patient and families. There is work underway which we've reported on to the Parliament in terms of the individual case review and so on and so forth, but it is also subject to the public inquiry and to the independent review that I commissioned just about a year ago, which we'll report in the spring. So in terms of infection prevention and control and engagement, there is not a specific timeline there for Greater Glasgow and Clyde. On the other area, which is around out of hours and other areas of performance, there is a turnaround director that we have put in, directly accountable to me and through the Oversight Board, which is chaired by John Conahan, our Chief Operating Officer for the NHS. That turnaround director will be producing a clear plan of improvements that need to be made in out of hours and in other areas, and that will have a timeline. And again, I'm happy to share that with the committee when that is finalised.
So non-financial timelines will be made available also?
Yeah.
Okay, thank you very much.
With the possible exception of Greater Glasgow and Clyde in terms of infection prevention and control and engagement, because there's no specific timing for that, given that it also feeds into the independent review and the public inquiry.
Okay, thank you very much. I think Alec Cole-Hamilton had one further point
I
on
have several further points actually, but not on brokerage.
this area.
This is a specific question on a budget issue.
Yep,
Yeah?
briefly then.
Ready to
Yep,
go?
please. Yep.
Fantastic. I'm sure all of the committee welcome the increase in spending, largely across the health service, with one exception. And I just wondered, whilst everything else is going up, why are we seeing a real terms cut to the budget for general ophthalmic services, particularly as our ageing population is going to depend more heavily on them?
So that is the 1% increase that you're referring to?
I think, yes, but in
Yeah.
real terms, that works out as a drop of 0.8%.
Yeah, yeah. So the planned spend is 109.5 million, which is just over $1 million over the current year. So there are a number, and any of this, there's two things to say. First of all, there are always difficult decisions to be made about where you put the bulk of your spending and the choices that you make. But in addition, there are a number of improvements coming in ophthalmic services using community-based optometry, which should produce a more efficient use of that resource. And that is reflected in what we have planned in the budget.
but that saving hasn't come in yet, but we are certainly going to see increased demand. And I visited my local optometrist this Friday and was learning about the preventative work that they do in terms of long-term savings by stopping macular degeneration, getting help fast. Pardon the pun, but does this not seem like a short-sighted cut?
So the work of optometrists isn't simply preventative. Optometrists can actually provide some of the direct care currently provided by ophthalmology as outpatients from the acute setting. So it's more than preventative. And we have a really quite excellent optometry service across Scotland that is currently underutilised in the skills that it offers. And in some of the investment that has been made in that service and that the service has made in itself. And so the work that will begin from memory across 3 board areas very soon will see an increased use of optometry services to treat as well as to prevent, and that will reduce the demand on ophthalmology services in the acute setting.
But that cut is going to be felt by community optometrists as well. They are seeing increased demand. You're expecting them to do more with less.
So I'm not arguing with what you are saying, Mr. Cole-Hamilton. My point would simply be, where would you suggest, of all the areas of level 3 and level 4 spend in the budget, that we would find additional resource to put into this area? That is always the case in terms of budget discussions. There is always a case to be made for additional resource to go into a number of areas that make perfect sense, but the decisions then have to be made about where that money will come from.
Great, thank you very much. Emma Harper.
Thank you, Convener. I'm interested in a couple of questions about NRAC allocations, and we know that the National Health Service Scotland Resource Allocation Committee, NRAC, have a formula that is used to calculate funding, and it's based on indicators like age, sex, population, rurality and deprivation. And in your opening remarks, you said that we are the closest to parity since NRAC was created in 2009 and 10. And so that seems that the Scottish Government does remain committed to maintaining NRAC parity. But can I ask whether the 2020 and 2021 allocations ensure that no NHS board is more than 1% below NRAC parity?
Yeah, thank you. So the draft budget provides a further 17 million in additional funding towards parity, and what that means is that no board will be further than 0.8% from parity.
And I'm sure that... Okay, right, thanks. And the formula that NRAC is applied, that is the best way of approaching how we determine these funds are assigned. So
I think the factors that are used within the NRAC formula are reasonable ones to consider: rurality, deprivation, age of the population. Seem the right kind of factors to me to be considering. And age works both ways, of course, because an older population produces a particular demand on our health service, but so too does a younger population. And in certain parts of the country, we see a growth in population size in those parts of the country, primarily made up of young people and families, youngish people and children. So I think that the factors are the right factors. I think there is a difficulty with any formula in that in its application there will always be winners and losers to an extent. That is why we produce the additional funding to, if you like, equalise the position so that no board is more than 0.8% away from parity, to try and compensate for the discrepancies that any formula approach will produce. The there are no proposals coming to me about a change in that formula, but I do think that all formulas deserve a review from time to time, and so I'm not against reviewing the NRAT formula, but I think we need to be realistic and recognise that any formula will produce some for whom it is of greater benefit than for others.
Okay, and the Scottish Government is committed to publishing data on the position of the boards related to NRAC, so you'll continue to
Yeah.
provide updates on that.
Yes, we will. Yes,
Okay.
we will. Once a budget is approved by Parliament, then we'll be able. So then we will know whether our current draft budget in health is as it is currently in draft, or whether there have been any changes to that. Then we will be able to show the allocation to each board and how that places them in relation to the NRAC formula and parity.
Okay, thank you.
Very much. Miles Briggs.
Convener, good morning to the panel. I wanted a follow-up question to Emma Harper's, because this time last year I asked those very questions around reviewing the actual NRAC formula. You said last year you were going to go and look at that, Cabinet Secretary. NHS Lothian have predicted historic underfunding of £365 million. £365 million over the last 11 years. Now, Lothian has the fastest growing population in Scotland, the fastest ageing population. You know the pressures on social care with the highest level of delayed discharges. We now also have the highest birth rate. So the NHS Lothian are warning us that they can't actually run the services based on this formula.
So in the draft budget of that 17.1 million that I said we had put in as additional funding in terms of parity, NHS Lothian are receiving 13 million of that. So they are by far and away, the next closest to them is Fife, who receive 1.8 million in order to take them to that 0.8% close to parity. So NHS Lothian's position, if you like, in terms of some of those factors that you've outlined, is recognised in, out of that 17 million, 13 million is going to NHS Lothian, which is miles ahead of any other board. Now, the difficulty then comes, I would probably dispute NHS Lothian's figures, but that's a different matter in terms of their historic claim. But the other area then takes us back to the position that Ms Cole-Hamilton and I reached on a different matter around ophthalmics, and that is if there is a case to be made that people want to pursue that would see NHS Lothian receive more than that 13 million, then I have to be advised where else in that health spend that is detailed in the budget down to level 4 would members suggest that comes. Because the fact of the matter is, if we bring all boards to NRAC parity without taking money away from any of those boards who are ahead, the cost of that is £1.3 billion. If we do it by taking money off boards who are ahead of parity in order to redistribute it, then Greater Glasgow and Clyde would lose 35.8 million, Western Isles 8.7, Dumfries and Galloway 7.6, Borders 0.9, Shetland 0.4. So those are the choices if we simply work within the formula, but if we don't want to do that, and we want to find additional money for any particular board for any reason, then we have to see where else in this budget are we going to take those funds? Is it from integration, from waiting times, from mental health? Because we've got to also remember that in the NHS there are a number of fixed costs. So the level of discretion that we can use on how we allocate those resources is of itself limited.
Well, with respect, Cabinet Secretary, these are your budget decisions. The SPICE briefing suggests that actually to finally close the gap, to lift every health board up, to have parity, would be £53 billion. Mm-hmm. Do you recognise that figure?
No, I don't, because the figures I've just given you are the figures that my officials have calculated, and those are the figures I work with. And with respect, at the end of the day, the Scottish Government's budget will be the Parliament's budget. And so it is incumbent on all of us, if we wish to suggest different priorities for resources, that we are clear not just where more money should be spent, but where it should come from. That is the responsible approach of all parliamentarians.
Just to be clear, Cabinet Secretary, I recall from memory that Nicola Sturgeon was the Cabinet Secretary for Health who gave a commitment at the time NRAC was first implemented to work towards 100% implementation. I think from the way you've described the funding allocations towards NRAC this year, it would sound as if you're working towards 99.2% implementation.
No, we would work towards that 100%, as the previous Health Secretary, now First Minister, said. But within the overall resources that I have and the decisions and choices I've made, I have moved all boards to 0.8%.
And do you have any timeline in mind as to when and whether 100% will be achieved?
No, because that does depend. I can't. I mean, it would, I can say as soon as possible, convener, and that's not a particularly satisfactory answer, I accept. But it depends on, because we're working in one-year budgets, so it depends on where we are in a year's time when we're looking at the following year's budget. But the commitment is there alongside the other commitments that we're working towards in mental health and waiting times and so on.
Okay, thank you very much. David Torrance.
Thank you, Convener. Good morning, Cabinet Secretary and Mr McCallum. The capital budget is increased by 92 million for 2021. What are the priorities for the forthcoming capital investment strategy and when will it be published?
So, just on the capital investment strategy, we were waiting for the Infrastructure Commission to make its report to ensure that our capital investment strategy could take account of what it had said. It reported from memory in January, and so we are reviewing our capital investment strategy to ensure that it takes account of the overall Infrastructure Commission's approach, and our intention is to be able to publish our capital investment strategy either immediately before the Easter recess, or either by the Easter recess or immediately after it. In terms of the priority areas, I'll let Mr McCallum deal with those.
So I think there's 3 or 4 things we're particularly focused on in the capital investment strategy. The first is to have an assessment of our current infrastructure, where that is, where our commitments are, and also where we're currently spending our money. So, for example, in 2020-21, obviously a lot of the additional investment will be around the new investment in the Bed and Anchor Centre and also the elective centres as well. We're then going to have the focus of the strategy will then be to see that context within that policy context. Where do we see the investment being required over the next 10, 15 years in terms of part of our longer term plans? And the key things that we're thinking about that, so we've already mentioned Attend Anywhere this morning. This cannot just be about investment in new hospitals, estate. It has to be much broader than that as well. So thinking about how we our local care plans and how we invest in primary care, but also how we make better use of digital technology as well. So that will form part of the plan. So I think they're the kind of key things that we'll be looking to draw out. The other thing that also picks up what was in the Infrastructure Commission is how all of that then relates to our climate change targets as well. So for the NHS in Scotland, being net zero carbon by 2045, and so that will be some of the information that's fleshed out as part of that capital investment strategy.
Are there any plans to use revenue finance to fund capital investment in health facilities?
So in 2020-21, no, it's all core capital funding that we are using. There are no plans currently in the health portfolio for any revenue financed schemes in the next few years. I know that across government and more widely there has been consideration of revenue financing schemes and how they would work. There is a model that's being looked at in Wales, minimum investment model, MIM as it's known, but at the moment there are currently no plans for any revenue financing schemes, certainly in the health portfolio.
Thank you.
Okay, thank you very much. Miles Briggs.
Thank you, Convener. I wanted to move on to integration authorities. I know we've touched on that already, but specifically around access to budget details, which I think the committee's found difficult, and looking towards decisions being taken by integrated authorities and the impact that clearly will have on the government's targets, but also on services across Scotland. Now, I make no apology for talking about the Edinburgh situation again this year with high levels of delayed discharge. Now, the Edinburgh IJB this week are looking to cut £36 million from social care services. The Cabinet Secretary's already outlined this morning, everyone around this table wants to see a shift from acute to community. What impact do you think that will have? And a quote I can give you is from Donald McCaskill, CEO of Scottish Care, who says the choices being forced on the Edinburgh IJB are wholly unacceptable. Now, we've just had a discussion about NRAC funding. It would seem to me that NHS Lothian are being put in a position where they can't actually offer additional funds to that IJB. So where, Cabinet Secretary, do you think this is actually joined up in terms of strategic funding?
So, first of all, I would want to understand why the IJB thinks that it has to make that level of cut to its budget and what is that's driving that, and do some work with them to understand that better. And secondly, the point I made earlier about joint accountability. So part of the discussion that we are currently with COSLA is around how we can use an approach of joint accountability linked to outcomes that focuses on priority areas, and delayed discharge would be one of those, and how we can then help IJBs prioritise their spend in order to deliver on that and intervene and support them where that is proving particularly difficult.
And in terms of that discussion then, are you actively bringing every IJB to the table to have that pre-discussion before these cuts take place? Because, you know, a simple Google shows that practically every IJB is looking at these cuts across Scotland. The impact that will have on services will then clearly impact on the targets which we've set, local authorities. These are going ahead now, and unintended consequences will be quite clear. Now, we've had several meetings and discussions around the delayed discharge crisis here in Edinburgh. It's getting worse, and we're cutting services out.
So you have to look at this position in the round. So we have a number of IJBs sitting on significant reserves. Those reserves are public money that they were given to spend for a particular purpose that they have not yet spent it on. We have some IJBs who are in deficit, I think 3, possibly 4, who run an annual deficit, some of which is historic, and frankly, they never get out the bit. We also then have other IJBs who actively manage and deliver a very high quality service with no delayed discharge within budget. So what we have to do is look at, and what we are doing is looking with COSLA, because remember this is a joint venture with our local authorities, actively look at why is that there that degree of difference? Why can we have IJBs that operate within budget that is delivered to them on the same basis as any others, produce no delayed discharge, a high quality of service, high retention of staff, and not run a deficit, and equally not sit on significant reserves? What is it that's happening there in terms of the transformation and reform of service delivery that is clearly not happening elsewhere? And how do we use what levers we have, bearing in mind that social care is delivered through local authorities, either directly or through contract? What levers can we use in order to help all of the others to the standard that the best is already reaching? That is the process that is underway, but it is a process of negotiation, because the delivery of health and social care integration is a partnership exercise between government, the health service and local authorities.
No, I respect that descriptive situation, but the actual issue on the ground here in Lothian, you'll know, with an overheated economy here in Edinburgh, the specific needs, which, given, I think, delayed discharge is about 40% all for Scotland here in one IJB. Finding those solutions hasn't been forthcoming. It's just cutting out actual potential solutions at the same time as we're losing social care capacity beds as well. So it's
So that requires direct engagement from my officials and COSLA. And my officials are directly engaged. And I hope, as a consequence of the discussions around the budget, that we will also have the direct engagement of COSLA with local authority and the health board in these kind of situations to help us find the right transformational route out of that difficulty. Edinburgh is a particular case, I completely accept, given the nature of the economy here in Edinburgh and the population drift into Edinburgh and the surrounding areas. But we need to see the same level of shared accountability across the local authority as we have across the health service.
Moving on to another area which we have also been looking for further detail around is the allocation and outcomes focus for drug and alcohol partnerships and funding being delivered to those. And it's been difficult to audit that funding and the outcomes around that. I wondered, in terms of this budget going forward, what reforms you potentially have to look at that, to ask Audit Scotland to audit outcomes for IJB partnerships and for drug and alcohol partnerships. Given that we have a drug deaths emergency in this country, also what inspection regime you might look towards being developed for alcohol and drug partnerships as well.
So we have, as you know, in the budget allocated an additional £12.7 million to this area of work. That is on top of the baseline funding already in health boards, which from memory is £53 million. That's a significant amount of money. Obviously, the health boards report directly and we can see exactly what they are doing. The difficulty is, as you've said, in areas where the IJBs are responsible in the level of reporting and the timious nature of that reporting. We've made some improvements in the past year. We would look to further improvements around that agreed set of outcomes between ourselves and COSLA, so that IJBs will be reporting. Now, we have still to agree what those outcomes are with COSLA. Delayed discharge, I think it is reasonable to presume, will be one of them, but the use of drug and alcohol funds could reasonably be another, where the IJBs are directly reporting on how those funds are being spent, but more importantly, with what outcomes are expected. And of course, all of that then feeds into the work that the Drug Task Force is doing. Once we have secured agreement on all of those, I'm again very happy to make sure the committee knows what those are that we've agreed with COSLA and the frequency with which we will look at reporting not only on spend, but on outcomes.
Sandra Hart.
Thank you very much, Convener. And I want to go back to the integration authorities. I think it's really, really important. And the Minister Cabinet Secretary already said there's so many different aspects of it, from basically physiotherapy to etc. And I know time is short, so I don't want to go through a lot of, I want to get to the questions in that respect. I think we all agree that integration authorities are really crucial, basically, for the delivery of health, not just to the patients, but to the general public and people in Scotland as well. There has been concerns raised about the leaderships of integration authorities and basically also the budgets, why they are not responsible for the budgets, and sometimes it's the health service or local authorities as well. So I'll just get straight to the point, Cabinet Secretary. I mean, basically, how are the government addressing these concerns, particularly in the leadership with integration authorities, and in particular concerned over the integration authorities who do not have effective control over their budgets? And do you have evidence of integration authorities who do have good leadership and control over their budgets and they're successful? And do you identify what underpins their success? And can other integration authorities learn from that?
So, in terms of do we have evidence of integration authorities that are successful in terms of both their budget and their overall leadership? Yes, we do, and by and large, almost without exception. In fact, without exception, what you will see is that those are the integration authorities that are successfully delivering against delayed discharge and in other areas, because all of that goes together. In terms of leadership, there is a organisation of chief officers and others of integration authorities. I can't recall its name exactly, but it meets in conference every year. It undertakes a lot of work, and it's about sharing good practice. Chief officers of the integration authorities meet regularly, and I was with them along with Councillor Curry on Friday just past in order to work with them as closely as we do, for example, with the chief executives and chairs of health boards. We have opened up many of the leadership programmes that the health service runs, and is some of the work that's also undertaken by Solace and others to ensure that chief officers can be part of those leadership programmes, and also looking with the support of Solace at ideas of mentorship and so on between chief officers. So there's been quite a lot of work done in the last year around leadership training and support. The core, if you look at those integration authorities where they are effective, that's not to say they're perfect, they will have areas where they want to improve, undoubtedly. Really, at the end of the day, comes down to the quality of relationships between the parties involved, that is the local authority, the health board and the integration authority. I think integration authorities generally have moved away. I think a year ago at this committee, I talked about issues of legality and governance being, in my view, a proxy for not doing the job. I think we've moved away from that now. I hear very little by way of if the governance was only better, we could do X or Y. So we've moved away from that now, and people are much more focused on what needs to be done to deliver outcomes. The more they understand each other's practice, then, as in any area, outliers don't particularly want to be outliers anymore. They want to improve so that they are aligned with others.
Okay. Sorry, Chair, and I just wanted to ask just a small point of it. Basically, we were talking about the budgets earlier on, and one of the questions was that would the government, commit to basically integration authorities' budgets being presented every 4 weeks, rather than now I think it's every 10 weeks, is it?
Yes, we provide the information every quarter, but about 10 weeks after the quarter's end. So this is something that we can, as you know, with health boards, you get monthly updates on their position. That's something that we'd look to work with chief officers and chief finance officers, along with COSLA, to agree an approach where you could get that information more regularly, yes. Yeah,
it'd be helpful, sorry, Chair, because it would be there before the budget. Just now we get it after the budgets, so it'd be helpful in that respect.
Yeah, I understand that, but it would not be possible for us at this point to commit to 4 weeks or any other period, because, as Mr McCallum said, this is a joint venture with COSLA, so we need to negotiate what is an improvement on the current position.
Okay, thank you.
So a commitment to an improvement is certainly welcome. Emma Harper.
Thank you, Convener. I'm conscious of time, but I'm interested in set-aside budgets. I've raised this recently. There are some boards, such as NHS Dumfries and Galloway, who work with one local authority, so they don't even call set-aside budget. So, but we've taken evidence that says that some boards are managing set-aside really well, and others that maybe aren't. I'm just wondering if there's any action that's been taken to address concerns over set-aside specifically, and then what issues can we learn then from authorities that are managing set-aside really well?
Yeah, so I think this really links in a way to the last question. So where set-aside is working effectively is that there is that clear agreement across the system of priorities, that people are involved in setting decisions on budgets, which includes a set-aside budget across health boards, IJBs and the local authorities as well. I mean, Dumfries and Galloway is a good example where the set-aside budget it's fully delegated to the partnership, so all hospital services are delegated, and I think that's working well. And we're seeing it work well in other places like Grampian, where they've got a really good understanding of what the set-aside budget is, and actually, rather than getting into the nuts and bolts of the detail, actually what is the shift of services and care that can move out of the hospital setting into the community. I think in terms of your point about what next and how do we share that learning, so at the end of this financial year, we are going to undertake another review in terms of where all IJBs are in terms of implementing the set-aside budgets. And I think from that, taking the good practice that we're seeing in some places, we'll share that with the chief officers, with the chief finance officers and their local authority and health board partners as well.
Okay.
Okay, thank you very much. Alec Cole-Hamilton.
Thank you very much, Convener. I'd like to ask about mental health funding. Obviously, we can see from the metrics mental health funding is going up, but we know that there is a problem downstream with recruitment. Of the 800 link workers the Scottish Government had suggested it would recruit to GP surgeries, we're nowhere near that. Can you speak to how this budget will work on the ground and how we can make our aspirations in terms of mental health provision real?
So my apologies if I've picked this up wrong, just please stop me. So we are on track in terms of the 800 additional mental health workers. Though I have determined to do is to introduce an additional focus to where those mental health officers are appointed, to which places they are appointed, so that we can ensure that we see more of them in general practice, in an A&E setting, and in the overall commitment we talked about custody settings. What I'm understanding better from discussions with Police Scotland is that often it is not specifically custody settings where the addition of a mental health officer or professional psychiatric input would be best for them, depends on the size of their custody setting, but sometimes it is with them or there to be called on by them. So, for example, they are not spending time in A&E or in other areas where that's not the best use of a Police Scotland resource. So we are looking, as we look to implement the draft budget for 2021, how we can target the deployment of the remaining numbers that we need to recruit to get to our overall target of 800, to ensure that where there are gaps, we are filling those gaps.
Okay, thank you. We also understand that in child and adolescent mental health services, one of the principal drivers of excessive waiting times is a recruitment deficit. What additional work can the government do to close that gap?
So one of the key drivers of long waits in child and adolescent mental health services is actually the absence of earlier intervention and support, which then produces periods of crisis and referrals to the CALM service, which are not appropriate for the level of intervention that should be received from the CALM service. So that is why the investment in school counselling services and in additional school nurses, which is contained in the budget and will roll out in this coming year, will make a difference to the levels of referral to CAMS. So then the question is, what about the long waits of people who are already on that waiting list? And so there has been quite a lot of work done to increase the recruitment of practitioners to the CALM service, but also some work that Ms Hockey is undertaking, which is looking at what other professional input to CALMS can be made that is then appropriately used for different types of referrals to CALMS, if that makes sense.
It does. And you made the point about early intervention. I absolutely accept that. I met with Children First yesterday who have expressed to me grave concern that whilst they support the aspiration to recruit the numbers of mental health counsellors in Scottish schools that you have outlined, that there are insufficient numbers of counsellors trained in the necessary skill set to provide that service within our schools, and that recruitment might become an issue down the line. Do you share that concern?
So we're certainly looking at what more we need to do in order to secure the availability of that skilled and trained workforce. Just as we are doing when we say we want more GPs, well, what do you need to do then to produce these people? Similarly, in this area, as in other areas like allied health professionals and so on.
Okay.
Okay, thank you very much. Brief supplementary, Miles Briggs.
Just on that point, I think all of us recognise the amazing work which the third sector do in this field, especially around drug and alcohol, but also mental health. And some of the concerns which are often raised was around access to funding streams and actually future-proofing their services. Can I ask, is there any talk within the government and within local authorities as well around 3-year planning for funding around third sector services as well? Because I know some of the problems many MSPs have had has been actually around funding streams and actually the constant fighting for funding, which the third sector will often highlight to us.
So I think there's two parts to that. From memory, it will be about 2 years ago that Ms Constance, when she was the Cabinet Secretary for Communities, gave a commitment to 3-year funding for the third sector and introduced that. So that exists, that's not been resiled from. But there is another issue around funding which you have raised, Mr Briggs, in a debate in Parliament, which is around small levels of funding for very localised voluntary organisations that work in their own particular patch. They're not national in any respect. They have no wish to be national either. And what they need are small levels of grant that allow them to have a degree of security whilst they do all the other things that they want to do that is part of how they operate through fundraising and so on. I have some of those. I think Mr Whittle has raised it in my own constituency. And we are looking at what can we do that minimises the bureaucratic burden of applying for small grant funding of any size so that those smaller organisations can access relatively small sums of money quickly that will give them that degree of security, and they provide an exceptionally valuable resource in their local area.
And is that something you could look at? You know, I've visited GP practices where link workers actively are doing a good job, but the capacity out there doesn't actually exist. So a lot of their work is setting up men's sheds, gardening groups, walking clubs, whatever it looks like for their community. People's Postcode Lottery, I think, provide a lot of that initial funding sometimes for startups. To make them sustainable, is that a sort of a fund you could look at trying to set up or encourage organisations responsible to?
So, without making any absolute commitment, I'm always happy to look at ideas like that. I think one of the greatest resources we have in Scotland is actually our football clubs and the work that they do in terms of the community. That links very well across to social prescribing, links to some of the work elsewhere in government on loneliness and isolation. Now is spreading as football clubs are learning from each other about what they might do and are involved in work sometimes around men's sheds, but also reaching out in terms of dementia and other areas. And it's a huge resource that needs to be remembered when we look at what's available in any local community in terms of capacity.
Very much. That's a cue, I think, for Brian Whittle and sport.
Thank you, Peter. In your opening statement, Cabinet Secretary, and in the budget document, it states, and I quote here, being physically active is one of the best things we can do for our physical and mental health, helping to protect us from many of the most serious long-term health conditions and contributing significantly to physical and mental well-being. In an increasing health budget of over £15 billion, you have cut the sports budget by 1.6% to 45 million. How can you reconcile that initial statement with the fact that the sports budget has been cut?
So funding for Sport Scotland for 2 years, 2 consecutive years, was increased. And again, as I said earlier to colleagues, this is all part of at times difficult decisions that have to be made. Sport Scotland do a particularly important job, but so too, and of course as part of the funding, we've increased it for the past 2 years. It's standstill for this year, but we've also maintained our commitment to underwrite any drops in lottery funding that they experience. And as I've said, the work that they do is important, but so too is the work that our local authorities do, or in some senses, in some areas, through their leisure trusts, in terms of the link that they can make through social prescribing. And increasingly that is what we are seeing in some parts of the country, where social prescribing is linked directly to the offer from local authorities in terms of their leisure and recreation facilities. So if I give you an example, in East Kilbride, the work that is undertaken there through primary care using digital technology on hypertension links directly to social prescribing, and an interesting part of the evidence that they are producing is that where the individual no longer needs health intervention in terms of high blood pressure, they maintain the physical activity that they undertook in order to manage their high blood pressure in the first place. So there is a very useful connection made too in East Ayrshire. I'm sure you're familiar with the work that is underway there under the leadership of Eddie Fraser and with the Leisure Trust in terms of linking what is going on in primary care, social prescribing, the schools and the leisure facilities for East Ayrshire Council.
Actually, I sat down with Eddie Fraser last week specifically to talk about this, but the reality is, Cabinet Secretary, it's not standing still. It's been cut by 1.6%, and there's no logic in what you've just said there, because you either accept that we shift the balance of care upstream and deliver these services upstream, or it appears in your ledger downstream in a multitude of conditions like obesity and type 2 diabetes and MSK and all of that. So you either accept what the budget document says, and it's the best thing we can do for our physical and mental health, and you invest in that, or you accept that it's not one of your priorities. You can't have both of these, Cabinet Secretary. You have to do one or the other. And I think it was in November you said that there's the real call and a real need for social prescribing. And in our own document and debate that we had last week, we were calling for 5% of the budget to be spent on social prescribing. But if you cut the sports budget, where does that money come from to deliver on your own ambition?
So, the world is not quite as binary for me as it seems to be for you, Mr. Whittle. If you talk about upstream investment, then you will see upstream investment in education, in terms of the work that goes on in schools with young people through Curriculum for Excellence on nutrition, healthy eating, diet and activity. That doesn't come from the health budget. It comes elsewhere in government as well as from local authorities. If you look at social prescribing, much of the activity in social prescribing is not from the health budget, but is from, for example, those football clubs that I talked about, those third sector organisations that Mr Briggs mentioned, and others, the leisure trusts indeed of our local authorities. Again, not necessarily directly from the health budget, but if you add all of that together, then I think there is significant investment and support from government in trying to encourage all of us to make the right choices in terms of diet and exercise, but particularly encouraging our young people to develop those habits very early on, and not the bad habits that people like you and I have to try and overturn. So I don't accept that maintaining Sport Scotland on the same level of funding this year as they did last year is a contradiction in our understanding that diet, activity and so on are important components of a healthier lifestyle and therefore a healthier population.
Not only is it not accusing me of being looking at this in a binary sense, I'm looking at this through 40 years of experience, and I'm telling the Cabinet Secretary that you're suggesting that intervention at education level is where it's happening, but it's absolutely not happening there. You're driving inequalities here, and by taking the budget away from Sport Scotland, who you are charging with the health of the nation, you are doing contrary to what your budget statement says. If you think that sport is important, is as important as you say it is, you have to invest in it. And in an increasing budget, you've cut it. That doesn't make any logical sense at all.
So I am not exclusively charging Sport Scotland with the health of the nation. There are a whole NHS health sector. There's Public Health Scotland due to appear before us very shortly. There is Sport Scotland. There is the work that our local authorities do, both in terms of leisure and recreation and in education, and I do believe it is happening in education. Not consistently, perhaps, as so much else, but it is happening. And so I think that your charge is unfair. Health is making a contribution from this portfolio to that important work, but it is not work that exclusively sits at the feet of the health service or this health portfolio to drive forward. And again, I make the point, you are perfectly entitled to want to see increased investment in Sport Scotland, but if you do, you have to say which part of the health budget you would take that money from.
Have that conversation with him.
Thank you very much. Just very briefly then, the committee's recommendation on social prescribing was that integration authorities should work towards 5% of their budget specifically on social prescribing. Is that a recommendation that the government supports?
So that's a recommendation that we are very happy to discuss through with the integration authorities, remembering, of course, as I've said more than once, this is a joint venture, but also remembering to the points Mr Briggs has made about how integration authorities need to address the particular challenges of their budget and set those priorities. But it is part of what we are looking at with COSLA.
Thank you very much. And finally, Cabinet Secretary, the committee a couple of years ago made a report on engagement and highlighted concerns around the engagement of integration authorities. I was pleased to see the Ministerial Strategic Group on Health and Community Care in November saying that statutory guidance is in preparation in order to improve that level of engagement across the board to the level of the best. Could you indicate when that statutory guidance may be ready and how far it will differ from the guidance currently in place?
So the statutory guidance now that is being worked on covers both health boards and integration authorities. So it covers, if you like, the whole system. My apologies, Convener, I had a sneaking suspicion you would ask me this question, and I did mean to check when it would be ready, and I forgot to do that. We will do that straight away and drop you a letter with the confirmation of when you should expect to see that new guidance published. It will be different from the existing guidance, though. The existing guidance is a bit formulaic, which is about a process that you have to go through, whereas you know and I know that actual genuine engagement is a skill set and an approach that should be backed by a process, but the process is not the driver. And so the guidance takes an approach much closer to what we understand, I think, between all of us as genuine engagement and letting communities lead where they want services to go rather than a process that needs to be followed to the absolute letter.
Thank you very much, Cabinet Secretary, and look forward to receiving that further information. Can I thank you and Mr McCallum for your evidence this morning. We will now briefly suspend and resume at 11:45. Much, and we'll now resume business. The second item on the agenda is subordinate legislation and consideration of an affirmative instrument. The first instrument we're looking at today is the Alcohol Minimum Price Per Unit Scotland Amendment Order 2020. And I welcome to the committee Joe Fitzpatrick, Minister for Public Health, Sport and Wellbeing, accompanied by Louise Feeney and Julie Davidson. Welcome, Minister. I believe you will make an opening statement.
I'll be as brief as I can. Thanks, Convener, and thanks to the committee for taking evidence today. This is largely a technical amendment to the order which sets the minimum price per unit alcohol. We've been aware that there has been an issue relating to minimum unit pricing for wholesalers who hold a licence. Issue was raised at the committee previously. We've considered how to clarify the current legal position and decided an amendment to the Alcohol Minimum Price Per Unit Scotland Order 2018, which set the minimum unit price at 50p, would be helpful. This draft Alcohol Minimum Price Per Unit Scotland Amendment Order 2020 clarifies the current position that minimum unit pricing does not apply to sales to trade. This is a niche area and only concerns wholesalers holding a licence. We issued a consultation on the proposed method for clarification and received 11 responses. 8 of the 10 respondents who commented on the proposed clarification were in agreement with the proposed approach to amend the 2018 order. Intelligence from National Licensing Standards officers is that they are content that this is not a live issue in practice and are happy with compliance. Obviously happy to take any questions from.
Thank you very much. And as is will be the case with the following affirmative orders as well, we first of all have the opportunity for questions to the Minister and his officials, and thereafter we will move to formal debate and ask the Minister to move the motion. But are there any questions at this stage? A question from Alec Cole-Hamilton.
Thank you, Convener. Good morning to the Minister and your officials. Minister, I'm very grateful for you bringing this order. I was one of the people who raised this in 2018 at the time about the loophole for wholesalers. So I'm grateful to see that that has been closed. My question is actually more about the fact that we're still at 50p and the fact that this was an act which was passed a long time ago. It was not through no fault of the Scottish Government snarled up in legal proceedings, but over the period of that time 50p became not what it was, shall we say, and that actually the sort of impact that threshold will have is arguably lesser than, say, a threshold of 60p. What consideration is your government giving to readdressing this and coming back to it?
So I think that the point the member makes is well made. Interestingly, Wales, which is introducing minimum unit pricing on Monday, have chosen 50p as the price, the minimum price for Wales as well. What we've said, and I'll continue to say, is that we need to keep the price under review. We've said we should do that after 2 years, so we're not quite there. So we need to look at the data from that and make sure that, you know, whether 50p remains an appropriate level. We need to be mindful it's about affordability, so there's a number of factors we would have to consider before deciding to make a change, but that is something I can confirm that we will be considering this year.
Thank you very much. Miles Briggs.
Thank you, Convener. Good morning to the panel. I wanted to ask a question with regards to research on the impact of displacement and potentially what we've seen in terms of a decline in cider sales, for example, but an increase in products like Buckfast tonic wine, let's call it. What sort of work have you done around potential displacement which has taken place, that people are still consuming levels of alcohol, but they're just not buying former products they used to?
First of all, to be clear, Convener, this order relates to a very technical clarification of a problem which in practice we do not think is live. In terms of the wider discussion about minimum unit pricing, obviously I was really pleased that ultimately all parties have come to the table in supporting minimum unit pricing. Really pleased that has been particularly supported elsewhere on these islands, particularly in Wales, and I know that in the Republic of Ireland they're looking at this too. Minimum unit pricing is intended to deal with the problem that Scotland has, that there is too much alcohol consumed. And the latest evidence that we have is that it is successful in reducing the level of alcohol consumed in Scotland. And that's in spite of a summer which resulted in an increase of alcohol elsewhere on these islands. So, you know, the policy intention is specifically to reduce the volume of alcohol, and it's being successful in doing that. And so we should be proud that as a parliament we've taken this move, which now others around the world are looking to emulate.
Thank you very much, Minister. And if there are no further questions, we will then move to agenda item 3, on the which is the formal debate on the SSI, which we have just heard from the Minister on. I remind members this is not an opportunity for questions. That has been. It is simply an opportunity to speak in the debate and come to a decision at the end of it. Can I invite the Minister to move motion S5M 20745?
I move that the Health and Sports Committee recommends that the alcohol minimum price per unit Scotland Amendment Order 2020 be approved.
Thank you very much. Can I invite members to contribute to the debate? Alec Cole-Hamilton.
Thank you, Convener. Just very briefly, I accept everything the Minister said about waiting for the 2 years to pass, and I think I look forward to continuing that discussion later. As it stands with this, I think this is an elegant fix to a problem I helped to identify in 2018. I'm grateful to the Government for bringing it forward.
Thank you very much. Brian Whittle.
I think the other thing I would like to raise, following on from Miles Briggs's question to the Minister, was I think we have to be, you know, welcoming this the minimum pricing to Scotland and the work that has been. And I think they have to be cognizant of that displacement, not just displacement within alcohol groups, but with the displacement into cheaper drugs as well. So I think there's a little bit of work still to be done there, which you know, hopefully the Parliament can do.
Thank you very much. Miles Briggs.
Thank you, Convener. I think you know, one of the key aspects of this policy, which we all want to see, is a reduction in the alcohol consumption, but also the problem we have in Scotland with alcohol. But one of the key aspects which I think the committee need to really look towards is outcomes. And across Scotland, the number of sometimes hospital A&E admissions around this is still increasing. So it's something I think we need to collectively look towards as well.
Thank you very much. George Adam, followed by Emma Harper.
Thank you, Convener. I think on the whole, when we look at this debate in particular, this is seen as one of a basket of measures to help us in how we deal with our relationship with alcohol in Scotland as well. So it's not just the be-all and end-all, although it has made significant kind of inroads in the way the fact that people are drinking less and it's moving in the right direction. It's one of many other kind of tools that the government are using within this scope.
Thank you very much. Emma Harper.
Thank you, Convener. I think that this amendment that we're discussing today is separate from what has just been brought up. And I think what we really need to do is firmly look at any evidence as we are taking this forward, because I know there are people out there that are basically disclaiming what minimum unit pricing is achieving, and we need it to have time to embed, and I think we need to absolutely be very clear in what evidence is presented.
Thank you very much. Minister, would you like
Just to wrap up on some of that, I think Deputy Convener is absolutely right that the things that we are discussing here are actually not about the order, and I think that's understandable, because the order is just makes sense for the reasons that Alex Cole-Hamilton mentioned earlier. George Adam is absolutely right that we have never said, and I don't think anyone who's supported this policy has said this is the silver bullet that on its own. It is part of a basket of measures, and the evidence is that it is moving us in the right direction. I think there's evidence in terms of hospitalisation that you know, the trajectory we were on has changed, and you know, I'm not sure the assertion that Mr Briggs made in terms of increasing is actually entirely accurate, but it's early days. We would expect the health benefits of this policy to take a number of years to come into effect, but I think it's really important that we recognise this as part of a basket of measures. Crucially, in doing so, we've recognised the particular problem that Scotland has in our relationship with alcohol, so I think it's good if we are all speaking with the same voice in that. Clearly, it is important that we have the research to look at a wide range of factors around the implication of this policy, and that is happening. There is a range of research ongoing, and it's that research which is helping make it easier for others around the world to follow suit.
Thank you very much, Minister. The question is that the motion S5M 20745 be approved. Are we all agreed? We are agreed. Thank you very much. And we move on to the next item on the agenda. I know the Minister is staying with us, but his officials are swapping places. This item is the Public Appointments and Public Bodies, etc. Scotland Act 2003 Amendment of Specified Authorities Order. And joining the Minister at the table today on this matter are Derek Grieve, the Interim Head of the Health Protection Division, and Alison MacLeod from the Legal Department. So welcome, and once again can I invite the Minister to make a brief opening statement.
Thank you, Convener. You may remember that you had a useful discussion regarding the Public Health Scotland order in 2019 in November last year. That order constituted Public Health Scotland as a new national special health board, and it will begin to exercise its full range of functions from the 1st of April this year. This related draft instrument sets out an amendment to Schedule 2 of the Public Appointments and Public Bodies, etc. Scotland Act 2003, which lists the specific authorities which are subject to Section 2 of that Act. Appointments to the specified authorities must comply with the Code of Practice published by the Commissioner for Ethical Standards in Public Life in Scotland. The amendment in this draft instrument enables COSLA to nominate councillors for ministerial appointment to the Public Health Scotland Board. It does this by removing these appointments from the convener's remit. As set out at our previous committee session, the partnership between Scottish Government and COSLA is a new and intrinsic feature of Public Health Scotland. Our view is that the levers for improving and protecting public health lie at both local and national government level. Joint decision-making between Scottish Government and COSLA holds the potential to achieve real and sustainable long-term change. By allowing COSLA council nominations, this order is intended to reflect that vital partnership on the Public Health Scotland Board membership. Healthcare is clearly not the sole remit of our health and well-being. We know that social and economic conditions are equally significant. We focus public health reform on joint action on the many factors across the whole system that determine our health. As you know, the Scottish Government and COSLA committed to a programme of reform and 3 key actions, which were to establish shared public health priorities for Scotland, to establish a new national leadership body for population health, that is Public Health Scotland, which has now been implemented by the Public Health Scotland Order 2019, and to strengthen and support local partnerships to take collective action with communities to improve health and well-being. The collaborative approach to tackling the public health priorities is to be embodied through joint sponsorship arrangements for Public Health Scotland. Co-sponsorship will provide Public Health Scotland with an opportunity to support and influence national and local decision involving public health. COSLA's participation will emphasise the importance of local delivery in recognising and influencing the determinants of health. The Public Health Scotland Board will consist of a total of 13 members. Of those, the intention is that COSLA will nominate a shortlist of councillors, that 2 council members will be appointed to the Public Health Scotland Board by Scottish ministers. This draft instrument is required to remove these appointments from the Commissioner's remit and to enable COSLA to nominate councillors for ministerial appointment to the Public Health Scotland Board. The COSLA nominations are to be councillor members recommended for appointment based on merit. This practice of stakeholder nominations is a long-standing one for NHS boards, intended to reflect specific partnerships. Territorial NHS boards routinely have councillors appointed following local authority nominations. These appointments are also included as an exception in Schedule 2 of the 2003 Act to remove them from the Commissioner's remit. The response to the public consultation on Public Health Scotland supported the principles of COSLA nominations, with some responses noting that the nominations should be made through transparent and appropriate selection channels. We've agreed with COSLA that the national selection process will be merit-based, with oversight from the Scottish Government. Our belief is that this partnership with COSLA will bring better opportunities for innovation and integration across the system. There is good evidence that whilst the NHS has a crucial role, many determinants of health and are influenced strongly by local government. By way of joint sponsorship and diverse board membership, we can better influence and support wider local government decisions that will positively impact the public's health. Scottish Government and COSLA, in a new model of collaboration, have jointly contributed to the concept and structure of Public Health Scotland, and I believe that these COSLA nominations will ensure a strong local government voice and perspective on the board. I therefore move the order, and I'm happy to answer any questions that the committee may have.
Thank you very much, Minister. I have a short question. Simply, is it your view that this measure will complete the raft of legislative changes required in advance of the launch of Public Health Scotland? In
Yes, that is the case.
Thank you very much. Miles Briggs.
Thank you, Convener. The two councillors which you've outlined will be appointed. Obviously, I take exactly what you've said around transparency and merit-based. We know from the discussion we've just had with IJBs, the conflicts which sometimes exist between councillors sitting on IJBs and councils and health boards. Have you investigated any of that, given that we don't really know where the future around Public Health Scotland will sit, and any potential conflict of interest which these councillors might end up being in, given their appointments?
So I think it's really important that all of the members of the board are there to represent the board, and I think councillors are pretty good in the main at being able to wear two hats, and I think that is, you know, when the councillors are there, they're not representing COSLA, they're there as members of the board. The mechanism that COSLA are developing for these appointments is slightly different from what we've seen before, in terms of it being, I think, probably the first time that they've done a merit-based approach. So rather than just saying it's one particular party or other. So I think this is new, and it kind of reflects the degree of partnership that there has been in developing Public Health Scotland from its origins.
Maybe to suggest, Convener, that that's good to hear. I think maybe going forward for other public bodies, this merit-based approach is something maybe we can have shared with the committee as well, to see what that actually looks like.
Thank you very much. Are there any other questions from members? If not, we'll now move to the next item on the agenda, which is the formal debate on the order which we have just taken evidence upon. Once again, if I can remind members that we are no longer in a position of asking questions, but of making contributions to the debate. And can I invite the Minister to move the motion S5M 20750?
Formally moved.
Thank you very much. Do any members wish to contribute to the debate on this order? If not, and if the Minister has nothing further to add, the question is that motion S5M 20750 be approved. Are we all agreed? We are. Thank you very much. That is agreed. We'll now move on to agenda item 6. Once again, an item of subordinate legislation. Once again, Joe Fitzpatrick will speak to this in a moment. It is the Community Care, Personal Care and Nursing Care Scotland Amendment Regulations 2020, and on this occasion Mr Fitzpatrick is accompanied by Susan Brodie and Anne Mathy from the Scottish Government. Minister.
Okay, well, thanks again for the opportunity to speak to these amendment regulations. The draft affirmative order before the committee today reflects our continued intention to increase free personal and nursing care payments in line with inflation. The order, if approved, will continue to benefit self-funding adults resident in care homes. The rates are calculated using the GDP, Gross Domestic Product, deflator inflation tool, which this year is an increase of 1.84%. This will mean the weekly payment for personal care will rise from £177 to £180, and the nursing care component will rise from £80 to £81 per week. It's estimated that this rise will cost £2.2 million this year. This will be funded by an additional £100 million in the recent 2020-21 Scottish budget for social health care and social integration. The last statistics report available is the financial year 2017-18, and that showed that there are over 10,000 self-funders benefiting from receiving free personal and nursing care payments. I'm happy to take any questions.
Thank you very much. Are there any questions to the Minister on this instrument, which is, I think he has described as essentially a regular operating as required by the original Act. If there are no further questions, then we will move on to the formal debate on the instrument. And can I ask the Minister to move motion S5M 20741?
Moved.
Thank you very much. Does any member wish to contribute to a debate? If not, the question is that motion S5M 20741 be approved. Are we all agreed? We are agreed. That matter is approved. Thank you very much. We now move on to the next agenda item, which is the final affirmative instrument of the day. This is following on from primary legislation which was agreed by this committee only a few short months ago. This is the Human Tissue Authorisation Specified Type A Procedure Scotland Regulations 2020 in draft. And again, Joe Fitzpatrick will speak to this motion for the government. He is accompanied on this occasion by Fern Morris and Claire McGill. Minister.
Thank you, and thanks again for the opportunity to set out in the context in which this statutory instrument has been laid. The Human Tissue Scotland Act 2006 was amended by the Human Tissue Authorisation Scotland Act 2019 to introduce a statutory framework setting out how medical procedures which facilitate transplantation can be authorised and the conditions attached to them being carried out. These procedures are termed in the Act as pre-death procedures and are defined in the Act as the medical procedures which may be carried out on a person for the purpose of increasing the likelihood of successful transplantation after death, and which are not for the purpose of safeguarding or promoting the physical or mental health of the person. The Human Tissue Authorisation Specified Type A Procedure Scotland Regulations 2020, which are before you, set out the procedures which Scottish ministers consider are appropriate to carry out as Type A procedures within the framework of Section 16E of the 2006 Act as amended by the 2019 Act. These regulations list the medical procedures that are currently frequently carried out in an intensive care unit to facilitate transplantation, where donation for transplantation has been authorised and is proceeding. These medical procedures aren't new, as they are required to ensure that donated organs can be matched and transplanted. Without the ability to carry out these procedures, transplantation of organs is unlikely to go ahead in case of circulatory death, which is almost 40% of cases. The procedures are very important in helping to ensure that organs can be matched appropriately and transplantation is as safe as it can be for the recipient. The regulations are supported by the framework established by the 2019 Act, which sets out the conditions or safeguards which must be met before the procedures specified in the regulations can be carried out. And that includes that authorisation is in place and the duty to inquire has already been undertaken, that the person is likely to die imminently, that the decision to withdraw life-sustaining treatment has been taken, the pre-death procedures is necessary and is not likely to cause more than minimal discomfort to the person and is not likely to harm the person. These conditions ensure that the procedures listed in the regulations cannot be undertaken prematurely, but also reflect the limited time frame both donation and transplantation must take place in. In practice, if no more can be done to save the life of the patient, and only after the family has come to terms with that, a sensitive discussion about donation will take place. Carrying out these procedures will be discussed in an appropriate and sensitive way, and the duty to inquire means that they will not be undertaken before this discussion with the family takes place. In developing the regulations, the Scottish Government has worked closely with and taken the advice of clinicians working in intensive care and the donation and transplantation pathway to ensure that the procedures specified as Type A meet the requirements of the Act and reflect current practice. I'm very grateful for their input. We have also consulted publicly, and the draft regulations before you take into account responses to that consultation. I'm grateful to have the opportunity to provide some context to the SSI, and I'm happy to take questions from the committee.
Thank you very much, Minister. Can I see questions? Sandra White.
Thank you very much, Convener, and thank you very much, Minister, for this. I took very close interest when this was going through committee, and thank you for the paperwork. Just two questions, and I may contribute to the debate if I'm allowed. The first question is in regards to the practice duty to inquire, and you mentioned about consultation potential donor's family. The question is, if the donor doesn't have a family, the Scottish Government are permitted. I just wanted clarification on that. What happens if the donor doesn't have an immediate family and able to give their consent? And the second question I have is in the last paragraph of that, basically to ensure the public is aware. How do you propose to produce the publications to ensure that the public are aware of what's happening here?
So I think it's important, first of all, to remember that these are procedures which are currently routinely carried out. In terms of duty to inquire, I think an important aspect of our legislation is that duty to inquire has to have been carried out in accordance with the law prior to the pre-death procedures taking place. In terms of awareness, we're already started the process of raising awareness about the change in law, and folk may have seen the poster which is currently in many pharmacies, and there's some radio work, so we're already starting that awareness raising procedures. Fern, do you want to add anything?
I would add that the number of cases where there is no family or friends is very small. NHSBT estimates that in Scotland there might be 3 to 5 cases a year of potential donors where there's no family. As the Minister says, the bill includes a duty to inquire, and the guidance will set out steps that should be taken in the case where there's no family or friends.
Okay. Just a further question, the guidance that you mentioned there as well, which is good. When are we likely to know what that guidance is? I mean, my understanding was that we had a debate whether the Scottish Government would take over as the family, as you might say, in regards to that. So when is this guidance likely to be produced?
So the duty to inquire is, to make sure that there is no family. Guidance, the state, it's obviously works ongoing.
Yeah, the guidance has been developed to inform the training that will take place from the spring about the new system.
Okay, so well, we will see that, I presume anyway. Then the guidance, everyone will see that, Health Committee as well.
It will be published, yes.
Yes. Okay, thank you.
Thank you, Emma Harper.
Thank you, Convener. Just to clarify, as a former member of a liver transplant team in Los Angeles, these listed procedures are usual carried out. They're blood tests, x-rays, urine tests, maybe ultrasound. So procedures, as the Minister has described, that are carried out already.
I think that's yes.
Excellent. Miles Briggs.
Point, and it's good to see these regulations brought to committee. During the progress of the bill, I know some of the conversations were around NHS capacity, theatre capacity. It's not obviously in relation to this regulation, but could I ask where the government has been around assessing any potential need for investment in that? I think specifically in the Highlands, there was an issue highlighted during the passage of the bill.
I think we are of the view that the capacity is there for the implementation of this bill. I think we were very clear that we did not expect an overnight massive increase in trajectory, and I think it's important that we are realistic that I think the bill, and obviously Parliament agreed that the bill was the right direction of travel, but I don't think anybody was suggesting in Scotland certainly that there would be a massive increase in the number of people donating as a response to this bill.
Excellent. Thank you very much. If there are no further questions, we will move on to the next item on the agenda, which is the formal debate on this SSI. And can I invite the Minister to move the motion S5M 20837?
Formally moved.
And can I see members who wish to contribute? Sandra White.
Thank you very much. I just wanted to contribute the fact to thank everyone in this committee, and the Minister and the clerks and people who gave evidence, because at times it was quite a harrowing bill to put through, and I think everyone's listened to the people who came along and the committee as well, and the recommendations. So I just want to thank everyone for pushing this forward. I think it's a very important piece of legislation. I look forward to the guidance coming forward, and I would also perhaps ask the Minister the amount of attention that was given when the bill was going through on radio, television, etc. as well. I don't know about television, but certainly media-wise and the radio, that perhaps that might be a way of pushing forward to let make people aware that this is coming through, and rather than just posters being up in pharmacies and doctors' surgeries. So, thank you.
Thank you very much. Minister, are any other contributions from members? If not, Minister, do you wish to respond?
Just very, very briefly. Obviously, the advertising campaign will be ramping up as we move towards the implementation date of autumn this year. I think we're already on radio, for instance, but I think that is something we need to bear in mind to make sure that the widest range of people are aware of this change to the legislation. I think it's probably appropriate just to put on record my thanks to the committee for their consideration of this matter, and it didn't surprise me there's been more discussion around this than others. The committee's taken a very detailed look as the legislation went through. Really particularly want to add on the record my thanks to the clinicians who've assisted in developing these regulations, and we'll obviously continue to work closely with the clinical stakeholders as we move towards implementation of the Act in the autumn of this year.
Thank you very much, Minister. The question is that motion S5M 20837 be approved. Are we all agreed? That is agreed. Thank you very much, and thank the Minister and his officials for their attendance. The next item on the agenda is the consideration of two negative instruments. The Minister is not giving evidence on those, so we'll thank him as he takes his leave. These are the National Health Service charges to Overseas Visitors Scotland Amendment Regulations 2020 and the Personal Injuries NHS Charges Amount Scotland Amendment Regulations 2020. On the first of those, which is to amend the regulations in relation to NHS charges to take account of anyone entering Scotland who's not an overseas visitor entering Scotland who requires diagnosis or treatment of the coronavirus, COVID-19 coronavirus, to allow that to go ahead quickly. The Delegated Powers Committee notes that it's content with the reasons for bringing these regulations into force as quickly as they have, but as required by standing orders, the committee draws this instrument to the attention of our committee under reporting ground J for the failure to lay the instrument in accordance with Section 28(2) of the 2010 Act, which is in relation to time limits. I think certainly my view is the circumstances justify the action of the government in that regard. However, are there any other comments on that instrument? If not, is the committee agreed to make no recommendations? That is agreed. And are there any comments on the Personal Injuries NHS Charges Amount Scotland Amendment Regulations 2020? Do any members have comments on that instrument? If not, is the committee agreed to make no recommendations? That is agreed. Thank you very much. That concludes the public session of the committee. And we will therefore move into private session.